Hello and welcome to the 6th Longevity Snapshot, where we will take a look at how young plasma can speed up recovery from surgery in older adults. My name is Chris Linnell, and I am the founder and president of the Canadian Longevity Association, Canada's premier longevity nonprofit. If you'd like to find out more about what we do and how to support us, then please check out the links below this video. Also, please give us a like and subscribe to our channel. Ever since the first heterochronic parabiosis experiments took place more than 2 decades ago, whereby an old and a young mouse were surgically co-joined and the old mouse became younger while the young mouse became older, the idea has emerged that there are youthful factors circulating in young blood which could potentially rejuvenate older animals. Since then, numerous studies have taken place in mice which have proven this to be true. However, data in humans has been sorely lacking, until now at least. In this study, researchers sought to see what would happen if they gave older adults who were undergoing major joint replacement surgery young plasma, and whether or not that would change the proteomic profile and speed up their recovery. Let's start by taking a look at the study design. So first off, I should mention that this was a small study. Looking at B on the bottom left here, you can see that there were 18 patients in the treatment group and 18 placebo. The treatment, called GRF 6021, was a 5% plasma fraction, whereas the placebo was a saline solution. Both groups were given 4 infusions: the day before surgery, before the surgery itself, just after surgery, and the day after surgery. Blood samples for analysis were collected on those days as well, and the patients were followed for 6 weeks afterwards. Looking at the first set of plasma proteomic results, we can see here a visual representation of the 6,596 proteins which were analyzed. Now, I won't go into this, but it does seem quite comprehensive. Of more interest are the differences between the treatment and placebo groups, which we can see down here. What we have here is the differences between the 2 treatment groups in their proteomic profile. On the day before surgery, the day of the surgery before the surgery itself, on that same day after the surgery, and then the first day after surgery. And whereas the profiles were quite similar the day before surgery and before the surgery itself, they diverged quite considerably after the surgery and the next day. This can also be seen in these graphs below, whereby the black line is quite close to the red dotted line the day before and the day of before the surgery. The black line is further away from the red dotted line after the surgery and the next day. What some of those differences are can be seen in C below. The 12 pathways detailed here all deal with either inflammation or are associated with cancer. And you can see that before the surgery, they are not that much different. However, afterwards, and especially on the first day after, major differences emerge. Now, the authors aren't specific about this, but I am assuming that the pathways are higher in the placebo group. Next, the authors looked at the immune response, and on the left here you can see all the various different immune cells. On the right here we can see the activity levels of 2 proteins across those immune cells. On the bottom, NFKB is an inflammatory molecule, and it did not show any real change in activity, so lighter colors show greater activity. However, another molecule, STAT3, which elevated levels can lead to greater cognitive decline after surgery, there was increased activity over the course of the first day, as can be seen by the lighter shading on day 1 post-surgery. Looking at the overall differences here, with once again B being the day of the surgery but before the surgery, C the day of the surgery but after surgery, and D being the next day, there was no significant difference between the 2 groups before surgery, as can be seen by these 2 bar graphs, and the fact that the black line was fairly close to the red dotted line. Immediately after surgery and the next day, significant differences once again emerged, as can be seen by the differences between the 2 bars and the fact that the black line is quite diverged from the red dotted line. Next, they looked at specific immune cells, and in those immune cells, 2 proteins stood out from the rest, and they were PERK in Treg cells and Treg memory cells. PERK is associated with tumors and Parkinson's, and blocking PERK can be neuroprotective, so lower levels are better. The green bars indicate the treated patients, and the light blue bars are the placebo. And as you can see, levels of PERK in both these cells were much lower. On the day after surgery, 7 proteins in different cell types stood out. And the first three here involved STAT3, and as I mentioned before, STAT3 is associated with cognitive decline after surgery. So lower levels in these three cell types are a good sign. MAPKAPK2 is associated with tumor progression, so lower levels are also beneficial, and they were indeed lower in the treated group. IKB blocks an inflammatory pathway, so higher levels are beneficial, and it's good to see that that was the case here. CD8 is crucial for robust immune protection against infection, so higher levels are beneficial, and that is indeed the case here. As for non-classical monocytes on the right here, they can lead to greater inflammation, so lower levels are better, and once again, that is the case here. Lastly, when looking at the immune system, changes in STAT3 were mainly found in naive CD8 T cells here on the left, which are part of the adaptive immune system, whereas the other three on the right here are part of the innate immune system. So all in all, it appears that young plasma can dampen down the immune and inflammatory response to surgery, which should be a good thing. However, how does this impact patient outcomes, which is the most important point? Now, although the authors talked about it in the text, for some reason they decided to hide the figures in the supplementary section, which seems strange to me as I think these are the most important results. However, I think this is due to the fact that none of these results were statistically significant as there was such a small number of participants in this trial. However, what they found was, starting on the left here with fatigue and function, which is the time it took to reach 50% recovery in days. For the placebo group in gray here, it took 16 days to reach that time point, whereas for the treated group in green, it only took 12 days. In terms of the amount of time it took to reach only mild pain, the placebo group took 18 days on average, whereas the treated group took only 12 days again. In terms of opioid consumption, which is also obviously an indicator of pain, there was no difference over the course of 6 weeks, as can be seen by the black line here being pretty much the same. However, when it came to the 2 days they were in hospital, there was a difference. On the first day, the placebo group consumed 3.4 grams, whereas the treated group only consumed 2.3 grams. On the second day, the placebo group consumed 2.3 grams, whereas the treated group only consumed 1.9 grams. Lastly, in terms of the function of the operated leg or the time to mild impairment, there was no difference between the two groups. So what does this all mean? Well, firstly, this was a small pilot study, so these results are very preliminary. However, they do align with the mouse studies, showing that young plasma can reduce inflammation, which clearly has benefits in terms of surgical outcomes. There are two other things worth bearing in mind. Firstly, and the authors don't really mention this in the text, but the placebo group was considerably younger than the treated group. I mean, they were randomly divided, and the average age of the placebo group was 64, whereas the average age of the treated group was 71, so a 7-year difference. And that could make a quite considerable difference in terms of inflammatory response due to surgery. So the differences might have been greater had they been the exact same age. Secondly, was how young was this young plasma? The average age of the donors was 35, which is not that young when you come to think about it. Mouse studies have shown that the younger the plasma, the better the results, with the best results coming from umbilical cord plasma, which is pretty much as young as you can get. So the question arises, would these results have been even better had the plasma come from much younger people? Indeed, it's intriguing to think what the results would have been had they used umbilical cord plasma. However, this is just nitpicking. It's great to see results in humans as opposed to mice, and one can only hope that there will soon be many further studies using young plasma in humans. Based on all the results in mice, this is an area I'm very excited about. And with that, we've reached the end of another longevity snapshot. If you've enjoyed this video, please give it a like and subscribe to our channel. So until next time, goodbye.